Welcome back to another edition of the Deep Dive. Today, we're doing something very focused, very intense, and honestly, incredibly high stakes. We're going to simulate a specific environment. I want you, our listener, to just close your eyes for a second.
Okay.
Imagine you're a postgraduate student. You are preparing for your MD anesthesiology exams. Let's say the Gujarat University exams, which are known for being pretty rigorous.
Oh, they are tough.
Definitely. You're sitting across from the internal and the external examiners. The AC is humming, your palms are a bit sweaty, and they look at you and they drop the big one.
The big ticket physiology question.
Exactly. Cerebral blood flow and autoregulation. This isn't just about general knowledge today.
No, not at all.
This is about survival in that exam hall.
Yeah.
Our whole mission here is to take this stack of sources we've got, Miller's anesthesia, Morgan and McHale, Guyton, even some of the old DNB question banks, and just synthesize them into a model answer.
This is a guaranteed question. I mean, it is absolutely 100% going to come up.
In what form, though?
Well, it could be a massive 20-mark long theory question, or it could be a short note, something like, discuss the factors affecting CBF.
Or the worst one.
Or the dreaded Viva trap, where they slide a napkin across the table and say, draw me the autoregulation curve.
Oh, that's brutal. You have to know this cold.
You really do. And, beyond the exam, this is literally life and death.
Right. This is the bedrock of what we do.
It is. The brain is this incredibly demanding organ. And the key thing to remember, the thing you have to state up front, is that it has zero energy storage.
No backup battery.
None. Not like the liver or muscles with their glycogen stores. For the brain, flow is life. If that perfusion stops, you lose consciousness in, 5 to 10 seconds?
That fast.
And irreversible cellular damage, that starts happening in just a few minutes. So when you're the anesthetist in that room, you are the guardian of that flow.
So no pressure, right?
Just keep the brain alive.
Let's structure this exactly how a student should structure their answer in a long theory paper. We have to start with the introduction and the definition.
Right. You need a crisp, authoritative opening. Don't waffle. You start with, cerebral blood flow, or CBF, is defined as the volume of blood flowing through a given mass of brain tissue per unit of time.
Simple, but you have to nail that exact phrasing.
You do. And then, right after that, you hit them with the why. Why is this so important? The importance of adequate perfusion.
And this is where you bring in the numbers about how greedy the brain is.
Exactly. These are the numbers examiners look for. You have to quote them. The brain is only about 2% of your total body weight.
It's tiny.
It's tiny. But it demands 15% of your entire cardiac output, 1.5.
Wow, okay.
And even more impressive, it consumes 20% of your total body oxygen.
That is a massive fuel bill for such a small organ.
It is. And the anesthetic relevance, the why do we care part of the intro, is that every single time we administer an anesthetic, we are fundamentally altering this physiology.
Doesn't matter if it's a huge craniotomy or just...
Or a simple lap coal in an elderly patient. We are messing with the brain's fuel supply. And if you don't understand the rules of how to maintain that flow, you are, frankly, flying blind.
Okay, that's a perfect intro. Let's move to section 2, basic physiology of cerebral blood flow. The outline says this is very high yield. This is where we need the magic numbers.
These are non-negotiables. You have to write these down. Global CBF is 50 ml 100 Gmin.
50 milliliters per 100 grams of brain tissue per minute. Got it. That's the gold standard number.
That's the one. And that translates roughly to a total flow of about 750 millilem in an average adult.
Okay.
But you can't just leave it there. For the extra marks, you have to show you understand the distribution. The brain isn't, a homogeneous blob.
You're talking about gray matter versus white matter.
Precisely. Gray matter is where all the action is. It's the cell bodies, the synapses firing, the metabolic machinery. It's hungry.
So the flow has to be higher.
Much higher. It's around 80 ml 100 Gmin.
80.
And the white matter then. That's just the wiring. The axons. It's metabolically quieter. So the flow is much lower, down around 20 ml 100 Gmin.
So when you average the high flow 80 and the low flow 20, you land back at that magic global number of 50.
You've got it.
Yeah.
That shows the examiner you understand the nuance.
Now, in the exam, you always get bonus points for discussing the critical thresholds. What happens when that flow number starts to drop from 50?
This is the crucial clinical correlation. This is where physiology meets the patient. So flow drops from 50 down to about, say, 20 or 25 ml 100 Gmin.
Okay.
The neurons, they start to fail functionally. They're not dead, but they're not working right. See slowing on the EEG. They're alive, but they're sleepy.
So that's the first warning shot.
That's your warning. Now, If you drop further into the range of 15 to 20 ml/100 Gmin, the EEG goes isoelectric.
A flat line.
A flat line. The electrical function has completely failed, basically to conserve energy. This is the concept of the penumbra you hear about in stroke. The tissue is salvageable, but it's electrically silent.
But are the cells dead yet?
Not yet. But if you drop below 10 ml/100 Gmin, that is the cliff edge. That's the point of no return.
Irreversible cellular death.
Irreversible. The membrane pumps fail, calcium floods into the cell, the apoptotic cascade kicks off, and the cell dies.
So 10 is the number you never want to see. Now, to drive all this flow, we need pressure. Let's get into cerebral perfusion pressure, or CPP.
Yes, the formula is absolutely essential. You must write it down. CPP equals mean arterial pressure, MAP minus intracranial pressure, ICP.
I've seen some textbooks say MAP minus CVP, the central venous pressure. Which one is correct for the exam?
That's a great question, a potential Viva trap. The correct answer is it's whichever's higher, ICP or CVP.
Okay, why is that?
It relates to something called the Starling resistor concept.
Yeah.
It's a bit tricky, but really important for understanding neurophysiology.
Can you unpack that for us? It's a concept that always confuses people.
Sure. Imagine a soft, collapsible tube. That's your cerebral vein. And it's running through a solid, rigid box. That's your skull.
Okay, I can picture that.
Now, the pressure inside the box is the ICP. If that pressure inside the box becomes higher than the pressure inside the vein, what's going to happen?
It's going to squeeze the vein shut.
It's going to collapse it. It pinches it shut. So at that point, the pressure further downstream, the CVP, becomes totally irrelevant. Doesn't matter what the CVP is, because the point of resistance is now the external compression from the ICP.
Ah, okay. That makes perfect sense now. And since ICP is usually higher than CVP in a supine patient with a head injury...
We just use ICP in the formula. CPP equals MAP ICP.
And what are the normal values we should be quoting?
In a healthy adult, normal CPP is typically between 80 to 100 mmHg. But, and this is the clinical part, in practice, especially in a traumatic brain injury patient, we're usually targeting a CPP of greater than 60 or 70 mmHg.
We don't need 100 to keep the brain alive.
We don't. 60 to 70 is generally considered the minimum safe target.
Okay, moving on to section 3. Determinants of CBF. This is usually where you show off your grasp of basic physics.
Yeah, you can think of this as Ohm's law for the brain. You remember Ohm's law from physics, voltage equals current times resistance.
Vaguely.
Well, it's the same principle. Flow equals pressure divided by resistance. So for the brain, it's CBF equals CPP CVR.
CVR being cerebrovascular resistance.
Correct. So you basically got two levers you can pull to change the flow.
Pressure and resistance.
Exactly. You can either increase the driving force, which is your CPP, or you can change the diameter of the pipes, which changes your cerebrovascular resistance. And the body, for its fine-tuning, mostly relies on changing the resistance.
And this leads us directly into the most critical concept in this entire syllabus. Section 4, cerebral autoregulation.
This is the core. This is the heart of the whole topic. If you get this wrong, you fail the question.
Okay, so let's define it perfectly.
Cerebral autoregulation is the intrinsic ability of the brain to maintain a constant blood flow despite wide fluctuations in arterial blood pressure.
So it's the brain's way of decoupling itself from the chaos of the body's blood pressure changes.
That is a perfect way to put it. Your systemic blood pressure can be going up and down, but the brain keeps its own blood flow stable. It's a protective mechanism.
And for the exam, you have to draw the curve.
You must draw the curve. We call it the Lassen curve. It's simple. On the x-axis, you put MAP, mean arterial pressure. On the y-axis, you put CBF, cerebral blood flow.
And what does it look like?
You see this characteristic plateau, a flat line where flow stays constant at that 50 ml 100 Gmin level, even as the pressure moves across a wide range.
What is that range? What are the numbers for the plateau?
The historical classic textbook numbers, from Guyton, quote this range as a MAP of 50 to 150 mmHg.
50 to 150, that's the classic teaching.
It is. But, and here's where you really impress the examiner with up-to-date knowledge. You mentioned that newer sources like Miller's anesthesia point out a modern controversy.
Oh, this is good stuff. What's the controversy?
Well, that classic lower limit of autoregulation, the LLA, was always thought to be 50. But a lot of newer data suggests that for many normal people, it might actually be closer to 70 mmHg.
Wow. That's a huge clinical difference.
It's massive. It means our safety margin is much, much smaller than we originally thought.
So what happens below that lower limit, whether it's 50 or 70?
Below that limit, the arterioles are maximally dilated. They can't open up any wider to let more blood in. So flow becomes what we call pressure passive.
Meaning if the blood pressure drops, the flow drops?
Linearly, 1 to 1. And that is ischemia territory.
And what about on the other end, above the upper limit of 150?
Above that, the vessels are maximally constricted, trying to protect the brain from the high pressure, but eventually they just fail. You get what's called breakthrough.
Breakthrough.
The high pressure literally forces the vessels open. This leads to hyperperfusion, vasogenic edema, and the clinical picture of hypertensive encephalopathy.
So how does the brain actually do this? What are the mechanisms behind this amazing plateau?
You need to list 3 mechanisms in your answer. First, and probably the most straightforward, is the myogenic theory. It's simple. The smooth muscle in the arteriolar wall contracts when it's stretched. So if your blood pressure is high, the vessel wall stretches, and the muscle reflexively contracts to narrow the vessel and limit flow.
A simple mechanical feedback loop?
Exactly. The second, and probably most important, is the metabolic theory. This is the concept of flame metabolism coupling.
Supply and demand.
Perfect. The brain is working hard, producing metabolic byproducts, waste products like H+ ions, potassium, adenosine. All of these are potent vasodilators.
Ah, so if flow drops for some
The
reason.
waste products build up in that area. They can't get washed away. This buildup causes local vasodilation, which increases blood flow to that area and restores the balance.
That's very elegant. What's the third one?
The third is neurogenic control. Sympathetic and parasympathetic innervation of the cerebral vessels. Historically, this was thought to play a minor role in normal states.
But it is important.
It's very important in extreme stress states, like hemorrhagic shock or major trauma, where sympathetic outflow can actually shift the entire autoregulation curve to the right, helping protect the brain.
Okay, so that's autoregulation, the brain's way of handling pressure. But pressure isn't the only factor. Let's move to section 5. Factors affecting cerebral blood flow. This is often a standalone short note question.
Absolutely. And you have to have a structured answer. I'd break this down into 3 categories.
Yeah.
Chemical factors, retiology or physical factors, and temperature.
And the undisputed king of all these factors is
Carbon dioxide, PaSO2. It is the master regulator.
more powerful than pressure, even.
In terms of moment-to-moment physiological control, absolutely. The relationship between PaSO2 and CDF is linear and incredibly steep, specifically in the range between 20 and 80 millimilliton G of CO2.
So let's break that down. Hypercapnia, high CO2, what does that do?
It causes profound vasodilation,
Yeah.
a massive increase in cerebral blood flow.
And hypocapnia, low CO2.
The opposite, potent vasoconstriction, a significant reduction in flow. And you must quote the value here. Okay, what's the number?
CBF changes by about 1 to 2 ml 100 Gmin for every single 1 millimilli-HD change in PaCO2.
1 to 2 ml. That's a 2 to 4% change for every millimeter of mercury.
Right.
That is hugely sensitive.
It's exquisitely sensitive.
Why does this happen? What's the mechanism?
It's all about pH. Carbon dioxide is lipid-soluble, so it crosses the blood-brain barrier almost instantly.
Okay.
Once it's in the cerebrospinal fluid, CSF, it combines with water to form carbonic acid, which then dissociates and releases hydrogen ions, H+. And it's the change in local pH from those hydrogen ions that directly affects the smooth muscle of the arterioles.
Lower pH, more acidic means vasodilation.
Precisely.
And the clinical relevance here is huge for us in anesthesia.
It's a tool we use every day, controlled hyperventilation. If you have a patient with a tight, swollen brain and a high ICP.
You can intentionally lower their CO2. You get on the ventilator, increase the respiratory rate, and blow off CO2. This causes cerebral vasoconstriction, which reduces the total cerebral blood volume inside the skull, and that, in turn, lowers the ICP. It's a temporary life-saving measure.
But there's a real danger there, right? You can't just keep going.
A very big danger. If you're too aggressive and you drop the PaCO2 too low, say, below 25 milli-Hg, you can constrict the vessels so much that you actually cause cerebral ischemia. You choke off the blood supply.
So you're trading swelling for ischemia. It's a fine balance.
It's a very fine line.
Okay, what's the next chemical? Oxygen.
PaO2.
Oxygen's a whole different ballgame. It's not linear like CO2. It has more of a threshold effect.
What do you mean by that?
The brain is actually quite indifferent to high levels of oxygen. Hyperoxia, giving 100% oxygen, doesn't really change cerebral blood flow much at all.
So that's a common Viva trap. Giving 100% O2 doesn't cause major vasoconstriction?
It causes a very mild, clinically insignificant vasoconstriction. It's nothing compared to the power of CO2. But hypoxia, that's a completely different story.
Right. Once the PaO2 drops below a threshold of about 50 or 60 millimilli-Hg, the brain panics.
And it does what?
It triggers a massive, overwhelming vasodilation. It's a desperate attempt to increase blood flow to deliver more oxygen. But the side effect is that this dramatically increases cerebral blood volume and can cause a dangerous spike in ICP.
So hypoxia is a double whammy. You've got no oxygen getting to the brain cells, and at the same time, your ICP is shooting up.
Exactly. It's a lethal combination.
Okay, we've covered chemicals. What about the physical factors? Viscosity.
Yes, blood viscosity or rheology. This comes from the Hagen-Poiseuille law, if you want to be fancy. But simply put, flow is inversely proportional to viscosity.
Thicker blood flows slower.
Thicker blood flows slower. So in a patient with polycythemia, very high hematocrit, CBF can actually decrease. Conversely, in anemia, with a low hematocrit, the blood is thinner and flow increases.
Is there an optimal level?
There is. The optimal hematocrit for balancing viscosity and oxygen carrying capacity is thought to be around 30%.
Good to know. And the last factor, temperature.
Temperature is all about metabolic depression. Hypothermia cooling the patient reduces the cerebral metabolic rate, the CMRO2.
It slows the brain down.
It puts it to sleep. And because of that tight flow metabolism coupling we talked about, if the brain's metabolism drops, the blood flow to the brain drops in parallel.
Is there a number for that?
Yes, and it's another good one to quote. CMRO2 decreases by about 7% for every 1 degree Celsius drop in body temperature.
7% per degree.
We also talk about the Q10 effect, which states that the metabolic rate roughly halves for every 10-degree drop in temperature. This is the entire basis for using therapeutic hypothermia for neuroprotection after cardiac arrest or brain injury.
Okay, this brings us perfectly to Section 6, Impaired Cerebral Autoregulation. This is a huge exam favorite because it moves from pure physiology to pathology.
This is where the rubber really meets the road clinically. When the brain is injured from a TBI, a stroke, severe sepsis, a tumor, it often loses that beautiful protective autoregulatory plateau.
So what happens to the vessels?
The arterioles become paralyzed. They become like passive, rigid lead pipes.
No more active contraction or relaxation?
None. They don't react to pressure changes anymore.
Right.
Flow becomes entirely dependent on blood pressure. If the MAP goes up, flow goes up and you risk edema. If the MAP goes down, flow goes down and you risk ischemia. The brain becomes incredibly vulnerable.
And there's a specific condition that doesn't abolish the curve but changes it. Chronic hypertension.
Yes. This is a critical concept.
Yeah.
The right shift of the autoregulation curve.
What does that mean, a right shift?
If a patient has had uncontrolled high blood pressure for years, their cerebral arterioles have adapted. They've undergone hypertrophic changes. They're thicker and less compliant. Their entire autoregulation curve, the plateau, is shifted over to the right on the graph.
So their normal pressure range is higher.
Exactly. Their lower limit of autoregulation might not be 50 or 70 anymore. It might be 90 or even 100 millimillis.
So let's make this clinical. I'm anesthetizing a 70-year-old man with a long history of hypertension for a hip replacement. I induce anesthesia, and his blood pressure drops to 120/80. I might be thinking, that's a great blood pressure.
And you could be stroking his brain. For that patient's brain, a MAP of, say, 93 might be well below his lower limit. He could be critically hypoperfused and ischemic, even at a blood pressure that looks perfectly normal to you.
That is a critical safety concept.
It's probably one of those important takeaways from this entire topic.
Okay, Section 7, effects of anesthetic agents. This is vital for the anesthesiology exam, obviously.
Right, and you should divide your answer clearly into two categories: volatile agents and intravenous agents.
Let's start with the volatiles: sevoflurane, isoflurane, desflurane.
The volatiles are, by their nature, cerebral vasodilators. That's their primary effect on the vessels.
So they increase cerebral blood flow. That sounds bad for a patient with high ICP.
It is, but at the same time, they are also potent metabolic depressants. They put the brain to sleep, so they lower the CMRO2.
So you have a conflict. The demand is going down, but the supply, the flow, is going up.
Exactly. This is the classic definition of uncoupling. Flow goes UP while demand goes down. This uncoupling increases the cerebral blood volume and can raise ICP. That's why we're always very cautious with high doses of volatiles in neuro cases.
Is there a safe dose?
Generally, the teaching is that below 1 MC, you might preserve some degree of autoregulation, but above 1 MSE, you reliably abolish it.
Okay, now what about the IV agents? Propofol, barbiturates.
Propofol is the hero of neuroanesthesia, and for a simple reason. It is both a cerebral vasoconstrictor and a metabolic depressant.
So they work together in the same direction?
Yes. Coupling is preserved, metabolism drops, and flow drops in parallel right alongside it. This is perfect for a tight brain because it lowers demand and lowers ICP at the same time.
What about ketamine, the traditional black sheep of the family?
ketamine is controversial. For your exam, the classic textbook teaching, and this is the safe answer to give, is that ketamine is a cerebral vasodilator that increases CBF, increases CMRO2, and therefore increases ICP. So you would traditionally avoid it in a patient with a head injury.
But what's the modern view?
The modern evidence is a bit more nuanced. It suggests that if the patient is properly sedated and crucially mechanically ventilated so you can control their CO2, ketamine is likely safe and may not raise ICP. But for the exam, unless they specifically ask you about recent advances, you stick to the classic teaching. Ketamine increases flow.
Got it. Safe answer for the exam. Section 8. CBF, autoregulation, and intracranial pressure. How do we tie all of these concepts together?
This is where you bring in the Munro-Kellie doctrine.
The box.
The box. The skull is a rigid, non-expandable box. Inside it, you have three things: brain tissue, which is about 80%, blood, about 10%, and CSF, about 10%.
And if you increase the volume of one of those components?
Another one must decrease to compensate, or the pressure inside the box, the ICP, will rise.
And the component that we, as anesthetists, have the most immediate control over is the blood volume.
Exactly, the cerebral blood volume, or CBV. And this is where it all comes together in a dangerous way, in what we call the vasodilatory cascade.
The death spiral.
The death spiral.
Yep.
Picture this. A patient has a head injury. Their ICP is already a bit high. This high ICP starts to compress the brain, so their cerebral perfusion pressure, the CPP, begins to drop.
Okay.
Now, what does the brain's autoregulation do when it senses a low CPP?
It vasodilates. It tries to open the vessels to maintain flow.
Right. But what does vasodilation do to the volume of blood inside the rigid skull?
It increases it. You're adding more volume to an already full box.
Exactly. So the vasodilation increases the cerebral blood volume, which raises the ICP even further. This higher ICP then lowers the CPP even more, which triggers
more vasodilation. It's a vicious cycle.
It's a vicious positive feedback loop that rapidly leads to catastrophic brain herniation and death if you don't intervene.
So we have to break that cycle by either aggressively raising the MAP or finding a way to lower the ICP.
That is the fundamental crisis of neuroanesthesia.
Which brings us to Section 9, clinical applications. Let's start with the most common scenario, traumatic brain injury, TBI.
For TBI, the Brain Trauma Foundation guidelines are the Bible. And rule number 1, the thing that has the most evidence behind it, is simple. Avoid hypotension.
Just one episode of low blood pressure.
A single recorded episode of a systolic blood pressure less than 90 millibars Hg is a major independent predictor of increased mortality. So you have to be vigilant.
And what is the specific CPP target in TBI?
The current guidelines recommend targeting a CPP of 60 to 70 millibars Hg.
Why not higher? Why not aim for 80 or 90 to be safe?
That's a great question. In the past, there were protocols, like the Rosner protocol, that aimed for higher CPPs. But we found that to achieve that, you needed massive amounts of intravenous fluids and vasopressors. This led to systemic complications, especially ARDS or lung injury.
So you were saving the brain but killing the lungs.
And you can actually worsen cerebral edema through increased hydrostatic pressure. So 60-70 millibars Hg is now considered the evidence-based sweet spot.
Okay, what about a different scenario? Acute ischemic stroke.
A completely different beast. In an acute stroke, the area around the clot, the ischemic penumbra, has lost its autoregulation. Those vessels are paralyzed and pressure passive.
So they need pressure to get blood flow.
They absolutely need it. You need a high driving pressure to push blood through tiny collateral vessels to salvage that penumbra. So we practice what's called permissive hypertension.
We let the blood pressure stay high on purpose.
We do. We don't treat the blood pressure unless it's dangerously high, like over 220 systolic, or if the patient is a candidate for thrombolysis, where the bleeding risk changes the equation.
Fascinating. Okay, Section 10. Common exam questions and Viva traps. Let's give our listeners some insider tips. What are the questions examiners use to trip students up?
Okay, here's a classic one. The examiner leans in and asks, so you have a patient with a large brain tumor. Does this patient have autoregulation?
And the knee-jerk answer from a nervous student would be no.
And that's partially wrong, which is what they're looking for. The nuanced, safe answer is, it's not an all-or-nothing phenomenon.
Yeah.
You would say, autoregulation is likely impaired or completely lost regionally in the blood vessels around the tumor, which lack normal smooth muscle. However, the rest of the brain may have globally intact autoregulation. That shows a deeper understanding.
That's a great answer. What's another trap?
The transcranial Doppler, or TCD. They might ask, does TCD measure cerebral blood flow?
And the answer seems like it should be yes.
But the answer is a firm no. TCD measures flow velocity, how fast the red blood cells are moving. Velocity only equals flow if the diameter of the vessel remains constant.
Which it might not.
Exactly. In a condition like vasospasm after a subarachnoid hemorrhage, the vessel narrows. The velocity will shoot up, but the actual volume of flow is dangerously low, so you can't confuse the two.
Excellent point. Okay, section 11. Diagrams. You said you have to draw to pass. What are the absolute money shots?
You need to have 3 diagrams practiced until you can draw them in your sleep. Number 1 is the autoregulation curve.
Okay, walk us through it.
X-axis, MAP from 0 to 200.
Yeah.
Y-axis, CBF from 0 to 100. You draw the S-shaped curve with the flat plateau. You must label the lower limit, say 50, 70, and the upper limit around 150.
And for the bonus points?
For the bonus points, you draw a second dotted line curve shifted to the right of the first one, and you label it chronic hypertension. The examiner will love that.
Okay, what's diagram number 2?
The CO2 and O2 response curve. Again, CBF on the y-axis, gas tension on the x-axis. You draw the CO2 line as a steep, almost linear line going up. Then on the same graph, you draw the O2 line, which is flat for most of the range, and then shoots up like a hockey stick only when PO2 drops below 50.
It visually shows how much more potent CO2 is.
Instantly. And the third one, if you have time, is the ICP compliance curve. Volume on the x-axis, pressure on the y. You draw that exponential curve that shows the knee where the brain's compensation fails, and a small increase in volume causes a huge spike in pressure.
If you can draw those 3, you've anchored your entire answer. Finally, section 12, summary and the exam conclusion. How do we wrap up a 20-mark answer?
You need a powerful, concise, concluding paragraph. Don't just stop, summarize. Something like this. In conclusion, cerebral blood flow is a tightly regulated physiological process governed by a complex interplay of myogenic, metabolic, and neurogenic mechanisms, all designed to ensure a constant energy supply to the brain.
That's a strong start.
Then you link it to practice. In anesthetic and critical care practice, the management of the neurologically vulnerable patient hinges on optimizing cerebral perfusion pressure, PaceO2, and the cerebral metabolic rate. Pathological states such as traumatic brain injury and chronic hypertension disrupt this delicate homeostasis, necessitating strict adherence to hemodynamic targets, specifically maintaining a CPP between 60-70 mmHg to prevent devastating secondary brain injury.
That is a perfect mic drop conclusion. Let's do a rapid-fire recap for everyone listening. The key take-home points, I'll list them, you confirm. Number 1, normal CBF equals 50 ml 100 Gmin.
Correct. Memorize it.
Number 2, CO2 is the most potent physiological regulator. The relationship is linear.
Absolutely. Master regulator.
3, autoregulation keeps flow constant between a MAP of roughly 50 to 150 mmHg, but remember the lower limit might be closer to 70.
Yes. Mention the controversy.
4, volatile anesthetics uncouple flow and metabolism. Propofol and barbiturates keep them coupled.
The key pharmacological point.
And 5, always be aware of the right shift of the curve in patients with chronic hypertension.
That will save a brain one day.
Memorize those points, practice those graphs, and you will absolutely ace this question.
You will.
And remember, this knowledge isn't just to get you through the exam hall, it's for the patient on the table in front of you. Thanks for joining us for this deep dive. Good luck with your studies.
Good luck.